The idea for this webinar really sprang from the concept of everyday endoscopy, and for most of us, 80 to 90% of our polypectomies are done with a cold snare. And if your experience is anything like my experience, it's far from straightforward all the time. And I've asked various people how often it's not straightforward, and some people say 5–10%. I don't believe that. I think it's probably more like 20 to 30% where it's not straightforward. So we thought it was important to really deconstruct what we do with cold snare polypectomy to make it as simple and as effective as possible. And obviously, because we're doing so much of it, we need to be doing it efficiently as well. So we don't want to be spending a long time doing it, but we do want to do it properly. So this webinar is all about when to do cold snare polypectomy, how to do it properly, how to do it efficiently, and we hope you enjoy it. David.
All right, so as Roland said, this is something about cold snare polypectomy and something about it being more difficult than you might think. We want to talk about lesion selection for cold snare polypectomy. We want to talk about en-bloc cold snare technique. We want to talk about the possibilities of doing piecemeal. And then we want to talk about how to predict and handle difficulty. This is a really nice slide of John's. And actually, this speaks to something that I've been trying to put into words for a long time, but something that this photo just tells everything. Why now are we talking about incomplete resection? Why now are we able to use an endoscope to see whether a polyp's microscopically been removed? Because we got vision, and we didn't, not even when I started training, and certainly not when Dr. Valori started training. So indeed, these images speak for themselves, that before we kind of maybe took a piece of a polyp, we had no idea whether it was off or not, and now we completely can tell. What are the benefits of cold snare polypectomy? It is quick, it is cheap, it is easy, and it is safe. But very commonly, people don't want to start doing cold snare polypectomy, and they say, yeah, but it's just a little, it's difficult. Maybe there's quite a lot of bleeding, some people might say, etc., etc. And so these things in red, maybe they can't easily get the polyp back. It's difficult to cut through. Sometimes they find it doesn't completely cut. It doesn't look very good afterwards. Not like a nice hot snare polypectomy defect where you just cut through and it's beautiful wide and maybe through the bowel wall. Incompletely resected, they think maybe because they're not sure whether they can see anything or not. And anticoagulants may seem to be a problem if you're worried about bleeding. So what we're going to go through all that, and we're going to try and debunk the myths. And of course, this is what you might see if you come back. Here you have a scar, and here you have a polyp in the scar later on. So how do you actually do cold snare polypectomy well? Well, this is a classic target for cold snare polypectomy. It looks like this, tubular adenoma. You have a snare. In this case, you have a hexagonal shaped cold snare, thin wide snare. You want to watch it close, and you want a margin of normal around the polyp that you're trying to resect. You want a little polyp sitting on a rim of normal, and you want to interrogate your defect afterwards. You're looking for this. This is my picture, or this, actually more of a realistic picture of John's, where the egg is the yolk is the polyp, and the egg white is that cuff of normal mucosa, and your snare is sitting right around. We're taking a load of egg white with you. I think we've illustrated that a little bit, and we're going to come back to that later. John, you want a little word about the bleeding and why bleeding is maybe not so much of an issue in cold snare polypectomy?
Yeah, absolutely, David. I mean, I have to say, I was late to the party. I was a great guy for a hot snare because it was clean and everything was well defined. And one of the issues with cold snaring, I felt, was there was a lot of bleeding, and that used to worry me slightly. And then I dug down a little bit deeper, and I think several things changed. Firstly, as David's alluded to, the visualization has improved dramatically. Secondly, we've had the advent of the water pump. Four things, maybe. Thirdly, we can inject and cold snare as well as injecting hot snare. And then finally, understanding of what layer you're going through when you're actually performing cold snare. So there's a small schematic on the on the screen at the moment, which shows you the layers of the colon. And this, we just moved the slide on one, David.
Yeah.
Then then we look at the vascular tree. So people who do ESD are very familiar with this, and the rest of you are probably not. And that there's big chunky vessels sitting deep down in the submucosal layer, so the SM3 level. And then as you go up through the levels of the submucosa, it branches like a tree until it reaches the top, where the permeating vessels are very, very fine. And your cold snare is going to cut through very, very superficially in SM layer 1. Sometimes it just picks up that muscularis, but sometimes it doesn't. Sometimes it's even above that. And therefore, the vessels that you transect are exceedingly small and therefore clot off very, very quickly. So even if there's a little bit of ooze at the time, you really don't have to worry about it.
Lob, maybe you want to comment as well. This is like to you previous to what you said, but sometimes in cold snare polypectomy, you can just push the snare out, can't you? And I wonder what happens here. I mean, here, just before we go to that, you see, because I think there's a lot of downward pressure, there's quite a lot of force pushing out, that as you close it, you have this kind of blink feeling that there's tissue inverting into the snare. Do you know what I'm saying, Lubka?
Yeah, that's exactly what I meant before. You have ensured there, you have the normal rim. And I think it's just fine now to press relatively hard, because as John said, you don't want an awful lot of tissue in your snare either, but it will work with a dedicated cold snare. And the other thing that we might do, because somebody asked on the chat, what if this is a morbidly obese patient and you just cannot move your scope any closer or move it a little bit to the left or the right? I think if Roland answered, you just remove a little bit more tissue and you're not sure that you have it all. But the other thing that I sometimes do is make a pseudo polyp by suctioning it to make it lift a little bit more, makes it much easier sometimes.
So
can I come in, David? We're going to come to this for sure, but the other way, if anything's ever difficult during polypectomy and you haven't injected anything, that's the other way to transform a difficult situation into a slightly easier one. So if you're not sure you've lifted everything, or you're not sure you've got everything, you lift, you see the margins much clearer. If it's difficult to get a hold of, you lift, it's much easier to get a hold of. And that is always a plan B option.
Yeah. All right. So the snare is closed. You watched it already try and transect once. It's been held for 10 seconds, nothing happening. So what can we do now, Xander? No, Xander. What can we do now?
Yeah, sorry.
Oh, he's there.
So the question was, what can we do now with snare stalls? Or
yeah, so stalling is the word. It has stalled, as in we're pulling on it with the snare wire. That nurse's or the assistant's hand is totally closed, and we've been in that situation for 10 seconds. So now we have this situation which we call stalling, and that's what that means. What can we do now? Get out the diathermic cable?
No, absolutely not, because you don't have a protective lift underneath the mucosa. The reason why it stalls is that there might have been too much bunching up of the submucosa, or might have been some muscle in it. So you can try do the guillotine method, while you pull it into your working channel with a little bit of, not really opening the snare, but a little bit of relaxing of the snare, that you can actually pull the polyp tissue off of the bunched up submucosa.
Yeah, so you see that happening here. And can you describe exactly what you do, Xander? Like how, because a lot of people often ask us, how hard can you pull on this?
That's a difficult question to answer. How hard can you pull? But
can you pull as hard as you can, like put all your extensive muscle bulk into the equation?
No, I wouldn't do that, especially not in the cecum. But you just, it's a slight pulling, but normally it doesn't take that much force.
Yeah, so firm, gentle traction, Lobke, Would that be what we can do, or can we do more than that?
Well, the last thing I learned from John actually was that wait a little bit longer, and I'm actually doing that now. You just said then 10 seconds. The last time, I think during a webinar, John said wait 30 seconds, and it actually works. Half the cases more will be cut through with the snare, and if that doesn't work, I also will apply the guillotine method.
John, how hard can we pull on a cold snare before it's dangerous?
I think you should avoid excessive force in any form of endoscopy, David, but there is good evidence to suggest that you can do an avulsion technique against the tip of the scope. If you've gathered a lot of tissue, you run the risk of, you can cause a perforation. It's very, very rare, but it can be caused, and it's almost certainly caused by this avulsion technique. So what I would encourage you to do is, just as Lob said, just take, you don't want to snap this thing shut. You want to slowly guillotine it so it divides through the tissue. If you have a lot of tissue, just wait. And if that doesn't work, you can just release it a little bit, then re-grab the tissue, and then any muscle should then drop out because you've grabbed the muscle. And then at that point in time, if it still doesn't go through, you can I would say gently pull against the end of the instrument. But I would have had that closed for maybe 30 seconds. I would have possibly opened and then reclosed it to allow the muscle there to drop out, and then I would have avulsed on the tip.
Yeah, I think it's a very sensible
David,
avoid excessive force in endoscopy in general. Yes, of course you can.
So I'm listening to this, and we haven't had this discussion, but I wonder whether there's a situation where you can apply too much downward force on the basis that preventing this happening is better than, much quicker and easier and safer than dealing with it. Is the problem here that there needs to be a balance between gathering the mucosa and not applying too much pressure so you get those deeper layers? And in the chat, somebody has asked, about doing this underwater. So can you consider those two things? Are we applying too much pressure sometimes rather than too wide an area? And the second question is, could this be done underwater more safely?
Yeah, well, this is a nice example to answer both of those things, I think. So the first question, are we applying too much pressure? And is that the reason? I presume what you're saying, Ron, is that if you applied less downward pressure, then maybe the snare would not capture so much tissue and you wouldn't get stalling, and you might just be able to cut
through. Absolutely. You wouldn't get those deeper tissues, which you're saying is the main reason for it stalling, as opposed to a wide area of tissue.
I mean, obviously, in this instance of what you can see here, you have a polyp that's nearly the same size as the snare. So you're going to need to exert pressure to stop, because the worst thing that you want to do is scrape the polyp and just take the polyp off and not normal. So I do think that's a balance. I mean, I'd be interested in the views of the others on that. John, is your view that can be prevented by pushing down less? Or that
I think there's two reasons you grab too much tissue. So I think if you have a lot of excessive downward force in addition to suction, because you're then using negative pressure to pull the tissue into the snare, more tissue than would normally be gathered by the snare, that's a potential source of a problem. And the second issue is when you've got the lesion growing around a fold. So it's an interesting observation. If you see a sessile serrated lesion that looks sessile, it isn't. It's flat. It just happens to be heaped up because it's growing around something, and then it's artificially looking elevated. And that's another area where you just go for simple cold snare and you end up gathering too much tissue and it's stalling and you're having this problem. So I think in both those circumstances, you need to think about which technique you're using. I think if you've got relatively flat mucosa as you have here, I don't think really you can have too much downward pressure. I mean, if you don't want to shove the thing through the mucosa, but as you're demonstrating here, if you keep pushing and keep pushing, you'll tip the snare. So instead of it lying flat, the end of the snare will tip up and it will pivot on the point where it comes out of the snare itself. So if you want to know you're putting too much pressure, you're not gathering the tissue at the tip of the snare. That tells you you've got too much pressure, and you're forming this, you're causing the snare to deform. Now, as I said before, you can lift And I agree, you can use underwater. The difference between underwater and lifting is lifting doesn't require gravity to be to your advantage. I use underwater a lot. I'm a great advocate of it, but you have to be in a section of the bowel where you can actually put the thing underwater. If you can, it's a great technique. The other option, again, as I said, is to lift. So I would say if it's very straightforward, you need enough pressure such that you don't cause almost, if you imagine a tick sign. So if you've got the snare catheter being the long arm of the tick, and you push your snare too far in, it will flick up and it won't gather the tissue. So you want to have enough pressure so that doesn't occur. And if you keep within that parameter, you're not going to have the problem, I think. You're not going to have a problem. If it's difficult, you have the option of lifting the lesion, or if it's appropriate, you can go underwater. That would be my advice anyway.